Welcome to the Explainer. Okay, today we are taking on a massive topic, and we're going to systematically decode literally every single detail of neurogenic bladder dysfunction. The goal here is to give you a detailed explanation without skipping a single point. We're going top down, starting right up at the brain and working our way all the way down the anatomical pathways to the peripheral nerves. By the time we're done, your conceptual framework is going to be so totally rock solid that you honestly won't even need to open the textbook. Let's get into it. Here's our quick roadmap for today. We're going to hit the stakes and definitions, move through supraspinal, suprasacral, and infrasacral lesions, and then wrap the whole thing up with specific urologic diseases. All right, Section 1, the stakes and core definitions. Look, before we even start mapping out nerve lesions, we have to talk about the why. Why do we care? Well, the absolute primary goal of all urologic treatment here is protecting the kidneys. It's really that simple. When the bladder dysfunctions, it can create this dangerous high-pressure obstruction that just backs up the pipes, basically destroying renal function. So managing the bladder, it is absolutely vital to stop that from happening. To understand exactly how that high pressure happens, we've got to build our vocabulary, starting with detrusor overactivity, or DO. Now, simply put, this is when the main muscle of the bladder wall, the detrusor, just contracts involuntarily. It acts on its own, giving the patient that sudden, intense urgency, and sometimes urge incontinence. Now, things get really dangerous when we introduce DSD, or detrusor sphincter dyssynergia. Normally, when your bladder squeezes, your sphincter relaxes, right? It's a coordinated effort. But in DSD, it's like a fight. The bladder squeezes hard while the external sphincter inappropriately fires and clamps shut right against it. It's literally like slamming on the gas pedal with the parking brake fully engaged. That shoots internal pressures through the roof and directly threatens those kidneys. Rounding out our big three concepts is detrusor areflexia. This one is exactly what it sounds like, the complete loss of bladder tone. The muscle is essentially completely flaccid. It just cannot contract enough to void, which obviously leads to profound urinary retention. Moving right along to Section 2, supraspinal lesions, which are located above the brainstem. So starting our descent down the nervous system at the very top, supraspinal lesions happen above the brainstem. Physiologically, what's happening here is a loss of centrally mediated inhibition. Basically, your conscious brain loses its ability to send a, hey, hold it in signal down to the pontine center. The brakes are completely gone. But here is a super important clinical caveat. Because the brainstem and the spinal cord below the lesion are entirely intact, normal coordination actually remains. So these patients definitely get detrusor overactivity, that sudden urge, but crucially, they get it without DSD. The bladder and sphincter still play nice and talk to each other, so the risk of high-pressure renal damage is actually quite low. Symptom-wise, you're going to see frequency, urgency, and nocturia. Oh, and if the sensory pathways get cut off too, the patient gets what we call insensate incontinence. It's incontinence of the unawares type simply because they literally cannot feel it happening. Okay, Section 3, suprasacral lesions and spinal shock. Traveling further down the spinal cord, below the pontine center, but staying above S2, we hit suprasacral lesions. Now, listen closely because this is a massive clinical trap. These injuries present in two entirely different ways, depending on exactly when you examine the patient. You absolutely have to understand this timeline. So, phase 1 is spinal shock. Right after a spinal cord injury, the bladder effectively just shuts down. It goes into complete detrusor areflexia. It will not contract. However, and this is key, the sphincter tone usually persists. So the bladder won't squeeze, but the door is locked shut. Because of this, urinary retention is the absolute rule here. They won't leak unless there's severe overdistension. Because of this, these patients require immediate, ongoing catheter drainage, either intermittent or indwelling, until the shock wears off, which, by the way, can take up to 6 whole months. Then we hit phase 2. Once that spinal shock finally subsides, the patient transitions into having an automatic bladder with reflexive voiding. They develop that dangerous detrusor overactivity combined with detrusor sphincter dyssynergia. Remember our definitions? The bladder is squeezing, but the external sphincter is clenching right back against it. This creates a functional outlet obstruction. Now you've got poor emptying and extremely high vesical pressures pushing straight back to the kidneys, which is a massive, massive risk for renal loss. Plus, because the bladder is constantly working out against a closed door, the detrusor muscle actually hypertrophies. The wall gets significantly thicker. Section 4. Infrasacral lesions. also known as lower motor lesions. All right, continuing downward below the S2 level, how do you actually distinguish between the lower motor nerve lesions here and the upper motor lesions we were just talking about? Well, you check the reflexes. Infrasacral lesions are characterized by the absolute loss of the bulbocavernosus reflex and the loss of the anal wink. If those are gone, you're looking low. In contrast, suprasacral lesions almost always preserve those reflexes, at least once they're out of that initial spinal shock phase. Physiologically speaking, because we are dealing with lower motor nerve damage here, infrasacral lesions basically guarantee detrusor areflexia. The bladder simply loses the ability to have voluntary or involuntary contractions. The motor is off. This drops the urinary flow rate and causes really dangerous retention. Eventually, the bladder fills to its absolute physical limit, like a balloon, and overflow incontinence develops. You'll also see this frequently paired with perineal sensory loss. Finally, Section 5. Let's look at some specific urologic disease processes. Now that we've built the framework, let's apply our anatomical rulebook to real-world diseases. For instance, a herniated lumbar disc. That usually starts with difficulty voiding or retention, though irritative symptoms can pop up later. Spinal stenosis? Well, the urologic symptoms for that vary entirely based on exactly what spinal level is compressed. Cauda equina syndrome, since it's a very low lesion, typically produces retention and overflow incontinence. And peripheral neuropathies, which we see a lot with diabetes, usually result in impaired detrusor activity. Then we have neurospinal dysraphism, like in myelodysplastic patients. This one is super interesting because it presents a highly specific dual finding. They usually have an areflexic bladder, but it's uniquely paired with an open bladder neck. It's basically an open funnel, so the bladder just continuously fills up until the resting fixed external sphincter pressure is physically exceeded by the weight of the fluid, and boom, that's when leakage occurs. Okay, let's take a look at our final two major complex conditions, multiple sclerosis and tethered cord syndrome. Now, both of these prominently feature our absolute worst enemy, DO with DSD. But let's see how they actually play out differently in practice. The key takeaway for multiple sclerosis is a massive clinical paradox. Check this out. 50 to 90% of MS patients develop voiding symptoms, with detrusor overactivity being the most common urodynamic finding. And yes, they often present with DO combined with DSD. But, and this is a huge but, despite having DSD, these patients uniquely manage to avoid the typical upper tract kidney injury or the loss of bladder compliance. It literally breaks the high-pressure rule we established earlier. It's a fascinating exception. Meanwhile, if we look at tethered cord syndrome, urologic complaints like urgency and incontinence show up on initial presentation roughly 30 to 70% of the time. And while their urodynamics also show DO with DSD, there is a really fantastic silver lining here. Surgical correction actually improves the urinary dysfunction in more than half of these patients. Not all of them for sure, but a really solid percentage. Now, I want to end on this quote because this is exactly why you cannot just blindly memorize a rigid list of symptoms from a textbook. As our source material explicitly warns us, over 50% of patients do not have a classic presentation or classic symptoms. You have to conceptually understand these underlying anatomical mechanisms, the supraspinal coordination, the spinal shock phases, the reflexes, because honestly, half the time, your patient's symptoms are going to try to trick you. So, having built this really comprehensive, completely top-to-bottom mental map of how the nervous system controls the bladder, you now actually have the conceptual tools you need, so you don't even need that book. I want to leave you with this final thought. Armed with this understanding of how bladder pressures dictate renal health, how are you going to apply these anatomical rules tomorrow to identify the precise lesion level and ultimately save a patient's kidneys? Keep exploring, keep questioning, and I'll see you in the next explainer.